This afternoon, I'm being joined by Dr. Mark Sherrid from NYU, who's going to talk to us about the speed bumps we can encounter while living with HCM and the speed bumps we just hit in life. So, Dr. Sherrid, thank you for joining us from your home and hope you're faring well during COVID-19.
Glad to be here.
Yeah. So just to give everybody a little bit of an update, because we've been talking to people from literally around the world over the past couple of days. How are things in New York? What are the rules you're living under right now? And how are you taking care of HCM patients during this time?
Yeah. So it's known that patients with underlying cardiac conditions can fare worse with this condition. It's known that the elderly can fare worse. So we're advising people to stay at home and to go out only when it's necessary, and to keep social distancing and ride this thing out and hope that it subsides um, um, by midsummer. Apparently, in Italy and South Korea and China, the number of cases are peaking and perhaps on decline. So these are countries that are very careful with social distancing and put people essentially in quarantine to prevent the spread of the condition. And so I think this is the most important advice that we can give. In New York, we're being hit very hard right now. I think we're still on the rise at this point. Um, and the hospitals in New York are filled with COVID-19 patients, not only um, patients with pneumonia, but also patients who've gotten so sick they've needed to have ventilators. And very sadly, there are patients who can't be oxygenated, can't get enough oxygen into their blood, even with intubation. And so these patients have died, and there is a temporary morgue which has been established near the medical examiner's office on our campus, which is really, really amazing. And I don't think any of us working at NYU thought that we would ever see the day when this would happen. So, um,
Wow, that was a bit sobering and a little harsh for those who are not living in a highly affected area right now.
right. So I only mention that because I think it encourages people to really um, stay home. Um,
Yes.
and I think that, we've all seen um, governors and mayors around the world. My favorite is Andrew Cuomo saying, "What is it that I am saying that you don't understand?"
It was a bit direct.
It's pretty clear what he's trying, the message that he's trying to get through. In America, we are rugged individualists, and we don't necessarily follow orders. And it's interesting that these three countries, China and South Korea, are countries where, because they've had threats, people follow instructions. In Israel, another country where people have lived under threat, people are following instructions and staying at home. And I think this is, as far as we can see, the way to get this under control. The idea that we should try to jumpstart our economy and send people back to work is inappropriate and ill-advised.
Yeah, I think we have to be very smart about this, especially for those with underlying conditions. We don't want to be pushed back to work any sooner than we need to be to make it unsafe for us. So that's a critical issue. So we hope you stay well on COVID issues locally. But let me ask this question. If patients have appointments scheduled with you, are they able to do telemedicine visits at this time? And if so, how do they set that up?
Right. So my secretary um, has been converting regular visits into video visits. And just the way I'm talking to you now, I can do that on my smartphone. And I can give advice, I can counsel patients, I can write prescriptions that get sent through the computer to the pharmacies. I can order tests. And I can look at tests. I can look at echocardiograms and CT scans, MRIs from my home computer. So I can do everything but listen to the heart. So I think that this last week, which was really the first full week that we did this, I probably saw 15 to 20 patients that way. And we're hoping to keep busy and spread the word about staying at home.
You've had a number of medical professionals at NYU come back positive, and I know they're being acutely aware of that and being real careful. I've seen it all over the news.
Right.
So it's a little tricky, and I'm really happy that you have found a safe way to continue to be able to be in contact with your patients through telemedicine. And we're all hoping that we see a lot more telemedicine visits in the future for patients who are traveling from a distance. It's becoming an easier way to get a consult.
Yes. In fact, some of the patients have said, hey, this might be a good way for me to see the doctor.
Mm-hmm.
And for people who have to travel 3 or 4 hours for a routine visit, I think that that's true. We were talking here about that all we really needed was a stethoscope that you could amplify the sound and send the sound over the internet, and that would be very helpful. We looked for patents, and actually patents exist for such a device.
I believe I've seen such a device in concept at a conference a couple of years ago.
Right.
And it actually didn't go through the computer, it went through your phone. And you could actually do heart sounds through the phone, and that you could pick them up there. And there'd actually be an analysis of what the computer thought was going on. And then you can confirm or deny that. It's
Right.
kind of a neat technology. We have to get some more data on that one. So let's get on to the topic of the day, which are how to manage speed bumps in HCM.
Right.
You always give crafty titles. Whenever I'm giving a talk, I get this crafty title that I've got to manage. And I talk to other people. What do you want to talk about? They get very specific. Mark has this image. It's a picture. And now we're going to paint that picture for you. So what are speed bumps?
So speed bump is anything that's, as you said, is not smooth sailing. It's not smooth driving. Basically slows you down, might shake you up a bit. And life is full of speed bumps. There is no life that is free of speed bumps. And I guess we had talked ahead of time about how these might include surgeries or procedures in the face of HCM.
Illnesses like viruses.
Interpersonal or personal disruptions like separations, divorces, deaths in the family. And then third, medical illnesses, of which COVID-19 is one of the more severe that you could contract. But these are they all have some things in common, but they all differ to a certain degree in how they're managed. And knowing how to deal with speed bumps is an important part of living with the HCM condition.
I use an analogy sometimes that living with HCM when I used to have it was like walking on a very wide balance beam. And sometimes your balance beam gets a little narrower and it's a little harder to keep balanced.
Right.
And then it balances back out again. It gets a little wider and a little easier to walk. So you call them speed bumps. I call it managing the balance beam.
Right.
And I think what we want to make clear to people today is, if you're dealing with an orthopedic issue, if you've got to have some other kind of surgery, gallbladder, gastrointestinal, weight loss surgery, orthopedic knee, elbow, everything. We've seen it all, but you also have HCM. So how do you manage that? And I'll get our next little tag up here. What is the role of the HCM team in handling these non-cardiac speed bumps?
Right. So for surgeries or procedures like colonoscopies or what have you, the key thing is to involve your HCM team ahead of time. so that if you gave everyone a month's warning, hey, I'm going to go in for an electric hip replacement, hey, I'm going to go in for a colonoscopy, we can get all the players informed, and make sure that first of all the medicines are continued, because the worst thing you can do as HCM is stop your medicines. And you should have a list of your medicines in your wallet or your purse so that you can show it to any doctor in any emergency room at any time. And
I will give a plug on that one. Anybody who becomes a member of the HCMA, we have an emergency contact card. We actually don't recommend you putting them always in your cell phone. You can put them there, but if you have a lock on your cell phone and an EMT worker has to find it, they can't get it. But a good old-fashioned paper card in your wallet, it's a charm. It's got clean data on it, and anybody can have access to it.
right.
Back to you.
So make sure the medicines are continued. And, there are hospitals that don't have some of the medications. And, if you're on bisoprolol, which is a less common beta blocker, it might not be in the hospital, and then you have to get some. And they may ask you to bring your own from home. If you're on disopyramide, it could take a day or so to get that from some outside source into the hospital pharmacy. So it's good to get ducks in a row, and it's good to bring your medicines with you. That way, if they don't have it in the hospital pharmacy, you can get permission from the physician to take your own. Okay, so then there's specifics for individual procedures. Basically, most HCM patients like being a little bit on the wet side as opposed to dry. That meaning avoiding being dehydrated. It's a good idea to stay full of fluid, because the patients, you do better if you're not dehydrated. Because if you're dry, then your heart shrinks because the blood just isn't there to fill your heart. And if your heart shrinks, that can make obstruction worse, or it can even make symptoms worse if you have non-obstructive HCM. So, for example, for colonoscopy, there's such a rigorous prep for that, which can cause fairly impressive fluid loss. We recommend starting the IV as soon as the patient arrives at the center where the colonoscopy needs to be done. And that's to prevent the heart from getting small and dropping the blood pressure and getting obstructed.
And in some cases, would you suggest that for certain types of procedures, people go to different types of facilities? Example, you can go to a colonoscopy center versus a hospital. You can have knee surgery in an outpatient facility or in the hospital. Insurance always wants you to go to the cheaper of the two, but what's right for an HCM patient?
So I think it really depends on whether it's obstructive or non-obstructive HCM for GI procedures, for colonoscopies. I think upper endoscopy is usually not a problem and can be done at an outpatient facility. But for lower endoscopy, the colonoscopy, there's so much dehydration. If a patient is obstructed, we recommend that it be done in a hospital setting. And we start the fluids as soon as the patient arrives. And the reason for that is that if the patient drops the blood pressure in the middle of the colonoscopy, you want someone to be around who knows what to do. And so this is what I refer to as the Joan Rivers syndrome. We all know the story of Joan Rivers, where there was a big flailing around when she got sick in an outpatient facility, and no one knew exactly what to do. I think that the same is true for hypertrophic cardiomyopathy. You don't want to get the wrong medications if you drop your blood pressure. You want to get the right medications. So we recommend doing it in the hospital, where they can call a cardiologist if the blood pressure falls, get an echocardiogram if the blood pressure falls.
Okay, so if we're managing physical symptoms and each kind of surgery really needs that good consult with our HCM doc, In some cases, would you recommend a cardiac anesthesiologist be available for some of these bumps, surgical bumps people may have, or is that not important?
For people who have a lot in the way of symptoms, it's a good idea to have a cardiac anesthesiologist. Because the presence of a lot of symptoms is telling everyone this person is barely compensated and needs really to walk a narrow beam, as you would say.
Mm-hmm. Okay.
Yes, cardiac anesthesiologist in that situation. Now, look, as far as the outpatients are concerned, let me just harken back to that for a second. Sometimes you have to be a little bit aggressive about this. You have to say, no, I don't want it to be done in a surgical center outside the hospital. Yes, I want to have it done in the hospital. Read my lips. Because they often want to do it on the outside, and you shouldn't do it on the outside if you have obstruction.
The other thing I would like to say that really doesn't have a lot to do with HCM, but it has to do with the business of medicine. Sometimes physicians want you to do it in a surgical center because they have ownership of that surgical center. There's a number of cases like that here in New Jersey where they, of course, want you in-house where it's all for them and they don't want to go to the hospital because then they have to give up some of the fee to the hospital. So understand that there can be motives that sometimes aren't your health and best interest, but somebody else's bottom line. So push a little harder.
I'm shocked. Shocked
and appalled. How could that happen in American healthcare? I'm sorry, I'm a little slap happy from being at home for 2 weeks now. Okay, so we've got that down. Now, there's other kinds of bumps in the road, life events.
Right.
So we talked about that a little bit in the beginning, explaining what a speed bump is. But can you explain how life speed bumps can physically affect the body and the heart?
So let's take the example of getting bad news. When we have an adaptive mechanism, a sort of fight or flight mechanism in our body, which is the outpouring of adrenaline. And adrenaline is designed evolutionarily to help us, for example, to run away from leopards and tigers. But it's left over, and we still have it. And there's an outpouring of adrenaline, which happens when we get bad news, if we get into a fight, if we get into an argument, if we get frustrated, if we have a life event that's filled with such emotions like divorce, separation, loss of a loved one. If we measure the amount of adrenaline in the blood in these situations, they can be sky high. One of the things adrenaline does is it causes the heart to contract much harder. And when the heart contracts much harder, that contraction can lead to more obstruction and more symptoms. It can also lead, even in non-obstructed patients, for them to get more symptoms. And arrhythmias, because irregular heartbeats can be triggered by adrenaline as well. So, it's not rare for patients to come in and say, I'm feeling a lot more short of breath, I'm having more palpitations, and the reason is because XYZ. And so sometimes it's appropriate to increase, for example, the beta blocker, which blocks adrenaline's effect on the heart. Sometimes it's appropriate to recommend counseling, a psychiatrist or a psychologist to help get a person through an acute life event.
So that's a fabulous way of explaining it. But sometimes physical stress on the heart, my dog is upset behind me because my husband just walked by. So I'm sorry, the dog's going to whine. COVID-19 times, baby. We have dogs in the office. So I was going to say, sometimes the heart can be so affected by stress. There's an actual mechanism for that, right? Or a disease process that starts. And we were going to talk a little bit next about your interest these days, which this kind of dovetails into one of your interests.
Right. So probably the most extreme case of emotion affecting the heart is a condition It's been termed broken heart syndrome. Another term for it is a Japanese word, Takotsubo syndrome, or stress cardiomyopathy. So this is a little bit far afield from what we're talking about, but it is related, so bear with me.
Dovetailing a little.
Yeah. So stress cardiomyopathy was first identified because elderly women, more middle-aged women, were coming into emergency rooms with what seemed to be heart attacks, severe chest pain or shortness of breath or a collapse, and were found when they were brought to the cardiac catheterization laboratory to have wide open, normal looking coronary arteries, despite the fact that their pump function was poor at the apex of the heart, apical ballooning where the heart wasn't contracting well. And one of the more interesting things that we've written about lately has been that some of the patients with this stress cardiomyopathy actually have obstructive hypertrophic cardiomyopathy as the underlying condition that has caused the stress cardiomyopathy. So, by the mechanism that I talked about earlier, in which emotional distress can cause increased adrenaline, increased contractility, more obstruction, more symptoms, the final stage of that is when the heart poops out because it's so obstructed. So if anyone in the HCMA has had stress cardiomyopathy and also has HCM,
Mm-hmm.
could let Lisa know about that because we'd be interested in hearing about it.
Yes, if anybody has this situation, and I know there's a few of you out there who I've spoken to over the years who have had both the diagnosis of hypertrophic cardiomyopathy and Takotsubo, and it doesn't matter which came first. Somebody could have told you Takotsubo and then you end up with HCM, or you had HCM and then all of a sudden somebody said Takotsubo and then they said, no, it's gone now. These mechanisms can happen. So if you've ever been told Takotsubo cardiomyopathy, let us know, and then we'll put you back in touch with Dr. Sherrid and his research.
So HCM is known as the great masquerader of cardiology. It pretends to be all sorts of other conditions. And this often leads to a delay in the diagnosis. Patients can have the misdiagnosis of mitral valve prolapse. They can be called coronary disease. Many patients get caths or even stents, while the main cause of their symptoms is actually HCM. Patients can be told they have anxiety syndrome or panic attacks, or HCM can masquerade as normals, the way it sometimes does in athletes. So, the spectrum of HCM can be very confusing, and Takotsubo, stress cardiomyopathy, is another way that HCM can present. And so, another way what I'm saying is that HCM can be the masquerade is actually stress cardiomyopathy. Enough said about that.
So you have another interest or something that is something you're proud of and part of, and
Yeah.
that's the technique. You want to talk about that?
Yeah. So we have an active surgical program at NYU, and a surgical colleague, Daniel Swistel, who I've worked with now for close to 25 years, and he's operated on well over 500 of our patients. And for many years, we've noticed that it's not just thickening of the septum that is a problem in HCM, but that the mitral valve is often elongated. The mitral valve, which actually touches the septum and causes the obstruction. Well, another aspect of the pathology which can cause obstruction is the long mitral valve. And so he has developed techniques over the years which have been adopted elsewhere to deal with the long mitral valve problem. So the idea is to fix everything at the same time and not leave any pathology untouched if the patient's having a surgical procedure. And so since 2011, he's been taking a very direct approach in some patients with obstructive HCM. And what he's done is, if I can try to show my hand here, let's see if I can. There. So this part's long and extra and redundant. And his approach has been to cut it off. So he first started calling it a tipectomy, which was to describe just reducing the length of the mitral valve by resecting or excising the redundant tip that serves no purpose in closing the valve, but it was only tending to promote obstruction. So the tipectomy, or now we call it the residual leaflet excision, has proven to be very successful, and we're working on pulling together our series of patients who've had that particular procedure done.
I usually refer to it as a little haircut on the edge of the mitral valve. Just
right.
those little edges off. Just a
little trim.
Just a little trim of the edges. But that little tiny trim can be all the difference when it comes to the geometry of the heart at that point and the flow.
Right.
And that's getting really geeky HCM, like when we get into it to that degree. But hey, that's what we talk here, geeky HCM. So other than the Takasubo and Dan's thing, we have a little project that you're working on. You want to talk about that?
Right. So this is a somewhat sensitive subject because it involves reproductive technology. Mm-hmm. And we know that individuals have different religious or ethical feelings about reproductive technology, and we respect those. But there are people who would like to see HCM out of the gene pool, would like to see individuals not inherit this condition. So if a gene is identified in a family as associated with an HCM condition, we call them disease-associated variants. The question that sometimes comes up in conversations is, hey doc, is there anything that we can do to prevent that from passing on to the children that we're hoping to have? And the answer is that in 2020, there is a possible way to prevent the gene from being passed on to the next generation. Now, this also broaches now on another sensitive subject, which is the subject of healthcare costs, because in vitro fertilization and PGT, that's the name of the technology, is expensive. And sometimes insurance doesn't cover it. Many states are including in vitro fertilization in their panels, and you can probably speak to the membership better than I can about the insurance. But we know from our practices that there are patients who have had successful PGT, used to be called PGD, and that stands for pre-implantation genetic diagnosis or pre-implantation genetic treatment. And I'll briefly tell you how it works. And I guess the question that arises is anyone in the membership of your HCMA contemplating this or has had this successfully or unsuccessfully? So nothing in medicine works perfectly. You have to acknowledge that up front. But this is a successful procedure in the overwhelming majority of patients. So essentially, you probably know that in vitro fertilization, embryos are produced. Well, if, say, 6 embryos are produced in the course of in vitro fertilization, by statistical odds, 3 of them will have the abnormal mutation and 3 won't. And through advanced methods, we can figure out which 3 don't have the variant, which 3 don't have the abnormality. And those are the 3 that get implanted, and not the other 3. So that's the way it works. And it's been successful in several of our patients. And we'd like to pull together a cohort of families where this has been attempted to try to understand how often it has worked, how often there are rare complications, and how often it hasn't worked, so that at least people are informed about their options.
If you want to go back in time a little bit, Pat Battle from NBC News in New Jersey or New York actually came out and interviewed the HCMA, and we brought in a woman who lives down in South Jersey who we helped get into a research protocol a number of years ago. And she's an HCM transplant. So with the use of a surrogate, she had used in vitro and PGD, and they got a bonus baby because it split and there were twins.
Right.
And they're HCM free.
Oh.
So it's possible. We confirmed the genetic testing when the boys were, a little bit older, and they're definitely clear of the 2 genes that mom had in that particular case. We had another one born right around Christmas who was clear, and another one out in California who is now going on 2 years old shortly. So they do work. It depends on your state whether they're going to cover the in vitro aspect. Most insurance is not covering the genetic testing of the embryo. They won't do that part, but that's not the most expensive part.
Right. That's not the most expensive.
It's actually rather inexpensive, but you want to make sure you go to a quality lab and that you have people looking at your genetic material and not trying to offer you PGD based on variants of uncertain significance, but only pathogenic mutations. I saw somebody try to be sold, oh yeah, we'll get rid of that VUS for you. That's probably the cause. It's not strong enough data to spend that kind of time and money and put your body through all of that.
No, you want to be reasonably sure that this is actually a disease-causing variant.
Yeah, absolutely. So we're going to try to get a registry going on those of you who are trying to do it, have done it, did it and failed, did it and succeeded. I know of a couple who they were a PGD attempt fail, and it was because as they were going through the process, there was a Friday night, a bottle of wine, and ta-da, a real baby. So that kind of blew that one out of the water. So remember, if you're going to do this, prepare. That was a little colorful there for a moment. Sorry. So we have a couple of questions for you, Dr. Sherrid. Let's see.
Why don't we talk about medical illnesses first?
I'm sorry?
Let's talk about medical illnesses.
Oh, sure. I'm sorry. We jumped over that, didn't we? So sorry.
Yeah.
Back to medical.
Because, that's what's going on now, right? We have this horrible medical illness. So the first thing is make sure you have enough medication. Make sure you have enough medication in your house. Make sure you have 3 months supply and refills available. Get your pharmacy to deliver it. If at all possible. They might just drop it off at your door so that you don't have to go to the pharmacy to get it. But don't run out of meds. Stay inside. Don't go out unless you have to. Social distancing is really important because you do not want to get this condition. We've had several patients in our practice who've had the virus. So far, no one terribly affected, but several have been hospitalized with it.
Have any of your patients been intubated at this point?
No.
Good.
No. We have generated internally a sheet that we actually have on our cell phones that we send to the doctors taking care of patients with other illnesses. We just email it to them. It's called Preventing Ash Crash. I think I sent it to you.
You did. I'll put that up on the website too.
Preventing Ash Crash. Ash is asymmetric septal hypertrophy, and patients can get, in the course of medical illnesses like pneumonia, or gastroenteritis, or strokes, or GI bleeds, especially GI bleeds, can get worsened obstruction, and we don't want patients to get that. And so the key thing is to continue the medications. Also, if there are medicines that you're on, and the doctors are suggesting giving you new medications, it's worth mentioning to them and making sure they understand the medicines that you're on already, to avoid interactions of those medicines with the medicines that they want to give you. There are some enzyme leaks in patients who have COVID. There's probably a myocarditis, which develops with the COVID-19. There is virus in the heart. It's all the more reason to stay inside and avoid getting it. Okay, so I think that's the
Oh my gosh. I have it. I have it as a Word document, which is even better.
Right.
Because I actually, probably not the most efficient way, but for right now, everybody can go into the comment box. Ooh, and you can all copy and paste it. It's all right there. Boom. That was nice and easy. It's a bit long, but I will post it as web content as well. That's the document. It's not very well formatted there, but you'll make do.
Anemia, HCM hates anemia, because, the problem is that patients get more obstructed with anemia. And, the problem with HCM is not enough blood getting pumped. If there's not enough blood in the body because you're anemia, that just compounds the problem. Can't tell you how many patients have come to see me, maybe 20 or 30 over the years, and they've said, "Oh God, I feel my HCM is getting much, much worse, much, much worse." And we do a blood count on them, and they're anemic. And then you say, "Well, what color are your stools?" "Oh, well, they're the color of a black telephone." And, "Oh, okay, well, the problem is that you're anemic, and that's why you're feeling so rotten. It's not your heart; it's that you're anemic."
Mm-hmm.
So that's an intercurrent medical illness that needs to be treated to get you better.
There you go. So that those are all good comments. And you have the document there. I'm reading in some of the comments here. Let's go to Joe's. If you need emergency surgery, I guess you would ask the ER doc to call the Center of Excellence doc. Yes. Would that be wise?
Right. Now, bear in mind that some surgeries you can't take by mouth. So that precludes giving you your oral metoprolol or your oral beta blocker or verapamil or the disopyramide that you're on. So bear in mind, when the anesthesiologist comes by, you look at them in the face and you say, "Hey, don't forget you can give me IV metoprolol." Because every hospital has IV metoprolol, which is a beta blocker. And that can be the biggest mistake that happens in the course of emergency surgery is holding the beta blocker. Patient's the blood pressure is a little bit marginal, it might be 95, the systolic blood pressure. Oh, well, we better hold the beta blocker. Man, that's a mistake. Big mistake. You got to give it. Even if the blood pressure is marginal, as long as the patient's perfusing, is warm, mentating, alert, making urine, you have to give the beta blocker, and it can be given IV. So that's the key thing. And remember, it's the anesthesiologist who's going to take care of you through the surgery and in the immediate postoperative period, not the surgeon. Your heart is in the hands of the anesthesiologist, and they're the ones who have to know what you have.
which is why, if possible, you ask for a cardiac anesthesiologist who are acutely aware of these things.
Right.
Actually, some general anesthesiologists don't like to take care of HCM patients or cardiac patients in general. They defer to a more senior anesthesiologist. So we have another question regarding COVID time. Carol said, you said stay inside. Walking around outside is not good with people, but if you have a path or a park, well, not parks aren't open, but walking on the street is still okay. We want you to get some exercise.
I think you should keep it to a minimum, but yes, you can go out. I mean, that's what the CDC says.
Yeah.
That's what
Don't
the
meet
CDC says.
people. Don't touch anything when you're out.
But don't congregate with anyone.
No congregating and no touching. No touching.
No touching, right.
You have a nasty habit of touching things when you're out for a walk. So we don't want to do that.
A lot of
Okay.
my patients are getting their walks because they have to walk the dog.
The dog's getting a lot of walks lately. She was doing well with far fewer walks 2 weeks ago, but she's enjoying it. Although I took her on a 3-mile hike up the side of a mountain, and she looked at me the next day like, do not put that leash on me, woman. So we deal with those. Okay. Are there any parting thoughts that you have? Because in just a few minutes, I'm going to come back on here with Marty Marin, and we're going to talk all things HCM. So Marty was available this afternoon, so you guys are back to backs.
Yeah. So, if you have questions related to COVID, call your doc. I mean, all doctors have made arrangements for calls to get put through to them. And it can be very reassuring to get some advice over the phone. Stay well, stay inside.
We have one final question, and I'll get it in before we say goodbye. Lisa wants to know if you need to have an A line in anytime you're going to have surgery, just because you have HCM.
No, not every time. I think it would be only for really the major operations. You're opening the chest, you're opening the abdomen, you're doing something on the brain. Yeah. Otherwise, no.
Good answer. Okay. And Carol said, thank you. So, Mark, thank you so much for joining us today. Please stay well. Please send our best wishes to the entire team at NYU during this very trying time. We appreciate everything that they're doing. And stay well.
Thanks for having me. Thank you for having me.
Absolutely. Thanks. And stop.